All right, everybody, welcome to CareFlight's LARPing Tactical Adventure at Revelry Peak Ranch. For this installment of CareFlight's education, for those of you on the CareFlight air side, is going to be coming out as part of the March-ish, I think March, yeah, monthly education, March or April. We're going to be talking a lot of trauma stuff today. First off, again, big shout out to our sponsor of the day, Revelry Peak Ranch, down here in Burnett, Texas. Beautiful place. We'll show you guys some really cool footage of the area around here. We've had some great help from the people at 911 TACMED as well. They just recently moved down here. Their education coordinator has been an awesome resource for us. Today we're going to talk mostly trauma, and specifically within trauma, a lot of hemorrhage control. Lots of different methods of controlling bleeding in different parts of the body. Some are easier than others. Like a lower extremity bleed might be something simple, but something junctional can be a little more complicated. All in all, we're going to have some fun with it. We're going to have the helicopter come out. We're going to ride around in some Humvees for no purpose other than for us to have fun, and it'll look kind of cool on camera. It doesn't really do anything else for the education. We have some great help from our local chief tactical paramedic and then the chief of tactical EMS at Collin County Sheriff's Office. And I think that's about all I have for you guys. So let's get into it.
Hey guys, so we're going to start running through all the different types of equipment that we're going to go through today. Each piece of equipment, I'm going to talk about the different types of products that they have available, the purpose that they serve, and then we'll go through and actually apply a couple of them to somebody in just a minute. So starting out, we're going to talk about tourniquets because that's going to be a big theme for today. This one should be pretty familiar to everybody, just the cat tourniquet. Most commonly distributed via North American Rescue, but there are other places too. Let's talk about the anatomy of a tourniquet. Most of these are going to apply to the vast majority of tourniquets, especially your windlass ones, but there are different varieties of tourniquets that we'll cover too. But anatomy for these, you have the actual band itself, which has a stretchy band that runs throughout the entirety of the tourniquet, which is why you cannot cut it. Obviously, you have the windlass right here, the actual securing clip itself, the time strap, and the buckle, which is going to come around on. Multiple different colors of different types of cat tourniquets. You have the black one, the orange one, and the blue one. Really common misconception is that the blue one is only training and it's not effective. That's not true. The only difference is color. So anytime that you get a cat tourniquet, they're all going to be effective. So second tourniquet that we're going to talk about is the soft tourniquet. This one, the major differences between this one and the cat tourniquet are you have a metal windlass. The securing buckle itself is very similar, but there's also a secondary redundant buckle. The actual strap itself, unlike the cat tourniquet, you can actually cut this if you wanted to get rid of some extra material. It does not have something that goes all the way through to provide any type of any more recoil or any more pressure. So unlike the cat tourniquet, you can actually cut this one. And then lastly, the actual securing portion of it, instead of going through a buckle, it's actually just a clip-on. So you can take it on, reapply it, pull this tight. Another type of tourniquet that we have, this one is going to look very similar to the cat and the soft and the other ones that you would use, but it's actually not intended for adults. So this tourniquet in particular is actually meant for canines. You can see it doesn't have a windlass, which is one of the main ways why, it's one of the main reasons why these tourniquets are actually effective as opposed to using something like a belt. This is just a pull to create the pressure. So again, this one is actually meant for canines. You can also use it for pediatric patients. We'll talk about a little bit of the differences why. But if you see something like this without a windlass on it, make sure you look at it really well because it may not be doing an effective job. It's probably not going to if you're actually trying to apply a tourniquet to cut off circulation for an adult person. One other type of tourniquets is just going to be an earlier generation of this one that we talked about. Very similar setup. The windlass is metal. There's this triangular securing device once you actually tighten the windlass all the way. And this particular method has a different securing mechanism. So it has this little screw. You can press down on it. It opens up these jaws. and you can pull the actual strap through itself. Once you get to the point where you want it to, release that, and then tighten that so you can no longer depress this, so this doesn't pull anymore. This is a lot less common than the cat tourniquet, for instance, which is going to be the most frequent one that you're going to see. So next one we're going to talk about is the TMT. This is kind of a combination of a couple different ones. It has a buckle on it. It's very similar to the soft tourniquets. Its mechanism for securing is very similar to the soft as well, where it just kind of snaps into place into this capturing loop right here. But it does actually work with a Velcro type mechanism as opposed to this, which is just a strap. And the last one that we're going to talk about today, somewhat similar to a ratcheting type tourniquet, which we don't have to demonstrate today, but it's just a different mechanism for tightening it. So instead of a windlass that you're actually going to see that's a stick, this actually functions a bit differently, where you are going to twist this, and it has a ratcheting mechanism that's circular, so you can continue to tighten it. And to loosen, you would just pull up on it, and it comes off all the way. So those are all the tourniquets that we're going to talk about. We're also going to talk about improvised tourniquets, which I'll demonstrate in a bit. But really the only thing you need for an improvised tourniquet is something that's rigid, that's going to actually be able to take a lot of pressure, and then ideally 2 different bandages that are at least 1 inch wide and that are strong enough to be able to take the pressure you're going to apply to it. So that could be 2 bandages just like these. Really commonly you'll see these triangle bandages that are used. But we'll talk about the procedure of doing that in just 1 second. We're going to be placing a tourniquet on Neil's arm. You can see and hear that there is a pulse that's present. You can put that down. So any type of cloth will work just fine as long as it's 1 inch in width and it has a windlass. I'm going to raise his arm up. And now I have my rigid device that I'm going to use as a windlass. Okay, you good? Mm-hmm. And okay. Twist it, and I can keep twisting it, and it'll keep applying pressure until there's no more pulse present. So, talked about tourniquets, the most common ones that you're going to see. We're going to move on and start talking about other things that we are going to address during this education. So, we're going to go over needle thoracostomies. We're also going to talk about finger thoracostomies and other chest injuries. Obviously, we should all be familiar with these spear needles, which we carry. You can see they have multiple different markings for depth, and then they're also have the angiocasts, which are fenestrated. You can see the small holes that are here. In addition to those spears, we also just have the longer 14 gauge needles. For sucking chest wounds or any type of penetrating chest injury, we are, of course, going to talk about different types of chest seals. These hyphen chest seals are the ones that we carry. They are a vented chest seal. Usually they'll come connected with this separation that you can pull these apart, but each one of these is just one individual. There's SAM chest seals, which actually come with a pretty rigid valve on them. So as opposed to the hyphens, which just kind of have a pathway that's built underneath it, this actually has a plastic valve that is able to stay a little bit more patent if there was any type of blood or other contaminant that gets into it. And then this is just another example of another type of chest seal that you may find. Usually they're going to come two in a pack. This one would be an example of one that's not vented at all. And then this is one that is vented. All right, talked about tourniquets, talked about some of the needles that we would use, and chest seals as well. This would be an example of something that we could use as a improvised chest seal, just a pair of expired AED pads or just any type of pad, obviously sticky adhesive. The only downside with using something like this would be, again, it doesn't have a vent on it. So that would be something that we would address a little bit later on and talk about considerations with that. All right, now we're going to talk about pressure dressings. So most commonly, you're going to see these types of pressure dressings, very similar to an Israeli bandage, where there's a built-in plastic piece that is able to apply more pressure when you're actually circumferentially wrapping it around an extremity or a junctional area. Let's see. So you can see the packaging on these is all fairly different. While they're not exactly the same, they do very similar things. So I'm just going to pick this one. So this one starts out with a particular area that you would place on there. And just wrap it over. Again, some of these are going to just be the cloth itself, the actual bandage. Some of them are also going to have a plastic piece on there that's going to allow for more pressure, which we'll talk about in a bit. This is a battle wrap, which is a clear adhesive bandage. So you would put down 4x4s or wound packing material or whatever, and then use this to be able to apply circumferentially, again, around to create more pressure. And you can also visualize the wound over it for the entirety of the process, which is a benefit that these other ones that are opaque do not have. SWAT tees, also another type of tourniquet that is very common. Another type of, sorry, what? Yeah. Oh, okay. Yeah. Okay. I mean, so yes, it can be used as, so SWAT tee, stretch, wrap, and tuck tourniquet. It can be effective as a tourniquet as far as cutting off blood flow distally. It's commonly used as a pressure dressing, but it can be used for either one. It just depends on how you apply it. So that's packaging for that. This is also another SWAT tee. It's just packaged in something a little bit different. These are basically just ace wrap bandages, still effective, still able to be used as pressure dressings, but they're just simple material with some Velcro, similar to this first one that we talked about. We'll talk about wound packing and we'll talk about wound closure devices. So the really common wound closure devices that we have to demonstrate today would be just something as simple as a stapler. There's also this device, an IT clamp, where if you're able to approximate the actual borders of the wound itself, you can use this to open up and grab each side of the wound and close it in on itself, and it holds it. Obviously, it stays pretty easy to be able to knock this off or actually hit it, but it holds pretty well. And the idea is that you're closing the wound around whatever type of bleeding there is, and it's going to create a tamponade effect and actually close it off. Wound packing material, a couple of different types. You may see us carry these two different types of packaging. There's no difference between the two. It's just a marketing scheme. They have the exact same material in them. The hemostatic agent that's impregnated into the gauze itself is just as effective regardless of which package you have. This would be an example of one that does not have the hemostatic agent in it. Still effective as a pressure dressing, or I'm sorry, still effective as, so this would be an example of wound packing material that does not have the hemostatic agent that's impregnated into the gauze. It's still effective as wound packing material. It just doesn't have that additional benefit of having a hemostatic effect. This is just another example of quick clot. It's going to be the same thing, has that hemostatic agent in there. Here, actually, I'm going to open these up. So you'll see that it has the radio-opaque lining through it. And these are just Z-folded on themselves for ease of administration. Okay, so we'll talk about pelvic binders, the pelvic binders that we carry, as well as the SAM pelvic binder, which is a really common one that you'll see. We'll talk about utilizing improvised junctional tourniquets, and then we'll also talk about commercial junctional tourniquets, which you can see looks really similar to the SAM pelvic binder. Let's see. We will talk about let's see. So we're also going to talk about being able to put two tourniquets together to create a larger one if we needed to for patients who have exceptionally large extremities. You can also use both of these together, and as well as a SAM splint together to be able to create a pelvic binder. Lastly, we're going to address the other aspects of trauma care, which would be something like, which would be hypothermia in particular. We'll talk about the most effective ways to keep your patient warm, and then logistically, what's the easiest way to be able to make sure that they're warm and dry. I think that's it as far as going through all of those. So we're going to start talking about wound packing right now. So for this demonstration, we're going to use this wound in a box. Obviously, it's not actively bleeding. We would normally only pack something if it's actively bleeding. So again, for this demonstration, we're going to use this quick clot that we opened up earlier. First thing that you would do is identify that the wound itself is actually bleeding. BSI is obviously super important in this instance. If you can identify the wound and you can actually see it, the vessel that's actually bleeding, it's the quickest, most effective method is just to apply direct pressure using as small of a point as possible. It's not effective to do this, right, because you're dispersing a lot of the weight over a larger surface area. So using 1 or 2 fingers to apply direct pressure to it, if it's too deep or if you just expect that you're not going to be able to stay with this patient in this position the entire time, obviously applying wound packing material at that time would be best. It's best to continuously hold pressure and have somebody else get the wound packing material out. In this instance, I'm operating by myself. So as I'm still trying to hold pressure, opening this package up, and now I have my gauze. You're going to start small because the point is to maintain a small point of pressure, and you can either start it off into a ball or you can just feed the tail in of itself. So I'm going to start it out in a little bit of a ball so that I can apply more pressure. Place it as far down as possible, ideally on top of the actual blood vessel that you're aiming for. You're also trying to aim to make sure that you're pushing up against something rigid. The only thing that would be beneficial to push up against would be a bone, for instance. So ideally you're pushing into something that's hard as opposed to just soft material. Grab a little bit more material, push even further in. You're trying to fill up the entire cavity as much as possible and trying to maintain pressure as often as possible. So adding a little bit in, just like this motion. So I'm going around. You can either pack very specifically if you know where the bleeding is coming from. If you don't know where the bleeding is coming from exactly, you can kind of pack in all 4 directions, trying to just fill up the whole space. The more packing material that you can get in here, the more pressure is going to be applied to whatever bleeding blood vessel you have, and will hopefully achieve hemostasis that much better. So once you get to the point where you have a satisfactory amount of material inside the wound and you can't really add any more, then at that point you can place the rest on top. If you need to add in more material, that's also fine. Just get another packing material, another package of wound packing material, and continue to add it in until the entire wound is full. Again, this has a hemostatic agent on there. That takes time to actually work. So you would hold pressure here, ideally for about 3 minutes. If there's no hemostatic agent and you're just using gauze or another material, you're going to want to hold pressure for longer, closer to about 5 to 8 minutes is the recommendation. Once you've held pressure, continuing to apply pressure using pressure dressing. Again, hopefully somebody else is available to hold pressure for me. Applying this side directly over the wound, circumferentially wrapping it, and then using this pressure bar to continue to apply pressure. Alternatively, if you have an injury with a specific pattern in the junctional areas, so that's the groin, the buttocks, the shoulders, the neck, and you either don't have wound pack material or you have an alternative option like this IT clamp, and you can approximate the borders of the wound close enough, you can also use devices like this to be able to lock it into place and close it up. Staples are also an option too as well. If it's profusely hemorrhaging, that's going to be a little bit more difficult. Wound packing is probably going to be the easiest and quickest way for you to do that. So now you'll see this skill demonstrated in a scenario.
Hey there.
Oh, okay.
Hey, Matt. My name's Aaron. I'm a paramedic.
All right.
Here to help you out. What's going on?
So I was using an angle grinder and I got it.
Take a look at this. Oh, okay. Keep holding pressure right there. You're using an angle grinder?
Yeah.
Okay. And what happened?
And it just flew off and hit me.
Okay. I'm cutting your shirt right now. I got to take a look at that. Okay. Keep holding good pressure like that. Just like that.
Is it bad?
It looks pretty deep. Yeah. Keep holding right there. So I'm going to get some material and start putting some cloth and some gauze onto that wound, okay? Because they're bleeding pretty good. Alrighty, I'm going to move this. Good. Sorry, this is going to hurt, okay? I got to hold on to this really, really tight, all right? Do me a favor, keep holding pressure right there. I'm going to get another bandage so I can wrap it around, okay?
Okay.
Keep holding good pressure like that. Are you hurting anywhere else?
I don't know.
Okay. Alrighty, you can go ahead and let go. Alrighty, do me a favor, lift up this arm right here. And you can let go of that. Raise up that arm. Listen. And then hand right here and keep holding pressure, okay? We're going to get out.
So let's real quick cover some key concepts in hemorrhage control and bleeding, specifically the physiology and pharmacology of it all. Welcome to the little rooftop chat up here with me. I hopefully make it real quick and easy. First things first, we're going to talk the clotting cascade, all right? Then we're going to talk some different pharmacologic or chemical interventions that we can use for hemorrhage control. We're going to talk the use of different blood products. Different kinds you're going to find out there, either what we carry here on the helicopter in an ambulance, or you might find in a hospital. And lastly, we're going to talk one very crucial aspect of hemorrhage control, and that's hypothermia or prevention, really, hypothermia. So let's start by looking at the basics of hemostasis. There's two types of hemostasis: there's primary and there's secondary, right? Primary hemostasis is first and foremost vasoconstriction, clamping down at the vessels at the side of the bleeding to try and limit the amount of blood flow, right? The less blood going to an area, the less you can bleed out from there. The second is actually going to be platelet aggregation. That is still considered a primary hemostasis measure. The platelet plug is just a temporizing measure to temporarily try and control or stop bleeding. But then that platelet plug goes away. Hopefully by the time it dissolves, it has activated the other part of the clotting cascade that's necessary, also known as secondary hemostasis. Secondary hemostasis, or the clotting cascade, can be broken down into two major pathways. There's the extrinsic pathway, the intrinsic pathway. They come together to form that common. The extrinsic pathway is activated anytime that there is, external damage or trauma to the body, right? So anything from the outside that opens up that body, it releases what's called tissue factor. So a factor from the tissues of the body, namely the skin tissues, leak into the bloodstream from the trauma, and that activates the extrinsic pathway. The intrinsic pathway, on the other hand, is activated when damage occurs to the blood vessel itself from the inside most commonly. So you're going to see that most commonly in atherosclerosis, where fat and plaque builds up on the inside of that artery, eventually damaging it to the point that it releases its own special kinds of factors to activate that intrinsic pathway. And that will ultimately lead again to a clot buildup on the inside of that vessel wall. If that happens on the inside of a coronary artery, well, that's usually what we call an MI, or myocardial infarction, right? Both pathways, whichever one was activated first, or they're activated together in tandem, converge into a common pathway where they activate factor 10. Factor 10 then goes on to turn prothrombin into thrombin, and the thrombin then converts fibrinogen into fibrin. And fibrin is what actually makes that clot and makes that long-lasting clot to replace that platelet plug. Beyond factor 10, we also care about factors 7, 8, and 9. Those are factors that we're able to either give recombinant directly on their own or as part of blood products we'll talk about here in a second. But beyond those clotting factors, there's two more chemicals that are very important, two substances super important for the clotting cascade that we do carry on this helicopter and on many ambulances just like it, is calcium and vitamin K. So calcium is necessary in 5 distinct steps of the clotting cascade in both the intrinsic, extrinsic, and common pathways. It is independently involved in activating multiple factors in all 3 parts of the clotting cascade, whereas vitamin K is involved in the activation of 4 different clotting factors. I think it's 2, 7, 9, and 10, where it is absolutely necessary. So a deficiency of either one of these things, or both, is going to lead to either the inability to clot at all, to create a stable fibrin plug, or a very, very... All right, moving on to pharmacologic and chemical hemorrhage control. They're both systemic and topical agents that we can use to assist in the management of a bleeding patient. One of the key and most common systemic agents that we're all probably familiar with is tranexamic acid, resin, TXA. TXA is actually going to be worked by inhibiting fibrinolysis, or fibrinolysis, however you want to pronounce it, which is the process of breaking down a clot. And the key feature there to understand is that TXA does not inherently cause or promote clotting or the formation of clots, right? So you're not really running an adverse effect or a risk of causing a patient to clot. That isn't currently. We understand that TXA's role is solely to prevent that clot from breaking down, that fibrin clot from breaking down once it's been formed. In certain cases, we'll also use recombinant activated factor 7, especially in severe bleeding. This use case, though, is very limited. It's situational. Obviously, not something we're going to be doing pre-hospital, but we exist in the unique world of doing interfacility transfers as well, not just scene calls, right? And every now and then, these trauma patients arrive at these small hospitals aren't really trauma centers. They need to go to the big ones, so we might have these resources available to us at the sending facility. In addition to these, there are topical agents that can be applied directly to the wound. Hemostatic dressings like Quick Clot or combat gauze like we just saw just a few minutes ago. EMSs have them all over the country. We keep ours in this little pocket right here. Super quick and easy. It's that Z-folded gauze. They're either coated in a substance called chitosan or kaolin, and you just pack them directly in, right? They are locally acting rather than systemic. You pack them directly onto that wound, directly onto the bleeding vessel rather than just around the wound, right? Like we just learned. And we directly promote clotting at the site of bleeding. It can be super helpful depending on what type of injury.
And, it's up to you as a clinician to decide, does this patient need systemic, local, or both hemorrhage control? And now, let's discuss the role of blood product transfusion in hemorrhage control, particularly in the context of traumatic injuries, right? Because we know that we can also give blood products for certain medicinal bleeds or medical bleeds as well. First off, we have fresh frozen plasma, or FFP. FFP contains all of the coagulation factors along with plasma proteins. It's used to replenish these factors during massive hemorrhage and is a key component of many massive transfusion protocols. Some MTP protocols vary in ratios across the country. I think 1 to 1 to 1 is becoming much more common. 1 PRBC, 1 FFP, 1 platelet, right? Sometimes it's 2-1-1, sometimes, a varying degree of options. Nonetheless, it is essentially the same as the liquid plasma that we carry here at CareFlight. The key difference here is that FFP, when requested from the blood bank in the hospital, has to be thawed before it can be delivered. It doesn't take an extremely long amount of time, like a few minutes, so nothing crazy, but nonetheless, not ideal and definitely not suitable for environments like this out here in the open in the elements. Next one's going to be something called cryoprecipitate, or just cryo. This is something that, to my knowledge, I don't know of being carried by any EMS units. It is essentially concentrated plasma. All right, so it's going to be highly concentrated in certain factors versus others. It's going to have a lot more per volume fibrinogen, factor 8, and von Willebrand factor. It's especially useful when a patient is experiencing fibrinogen deficit, and that occurs when the patient has been clotting a lot for a long time. They've been throwing clots all over the place, whether they're DIC or they have multiple traumatic injuries, and they're just depleting the stores of fibrinogen. We can replace that specifically with cryo because it's so much more concentrated plasma. Additionally, it is a smaller volume, so in patients where we are actually concerned with volume overload, which again, in the resuscitating trauma patient, blood flow is usually not an issue, but you never know. There's unique scenarios. Cryo gives us that additional benefit. Lastly, we have platelets. Platelets are exactly what they sound like. They're the same platelets that are rotating through your body right now, hopefully. We just call them pooled platelets, and we keep them in the hospital the same way that we keep cryo or platelets or PRBC or whole blood, right? As they form, platelets are critical for primary hemostasis, as we talked about, that very first phase of forming that platelet plug at the site of the vascular injury. In trauma patients, especially those going under MTP, massive transfusion protocols, they run the risk of becoming platelet depleted, right? It is a living cell inside of the body rather than a chemical substance like some of the others that requires creation, development in the bone marrow, and maturation in the body before it's released effectively into the bloodstream. So if a patient is bleeding significantly enough and hopefully clotting significantly enough, eventually they're going to deplete those stores of platelets. So a very simple fix to that, luckily, thanks to modern medicine, is you check their platelet level, or you just empirically give them a unit of platelets or a few units of platelets after a certain amount of time. Obviously, these are not things that I've just talked about that would necessarily carry on EMS vehicles, right? They're a very limited resource that has to be well controlled, and we can do a pretty darn good job of managing just with PRBCs, whole blood, and plasma. However, we are often called, we're not just a senior response service. We also are called for inter-facility transfers from small, low-level trauma hospitals, or even hospitals that aren't trauma centers at all, that are themselves very resource limited, trying to get a trauma patient out to one of these major trauma centers here downtown. So you have to be prepared to recognize, we walk in and we hear one of these things is infusing, let's recognize its importance and make sure that we continue its infusion. Or if someone offers it as an idea, or you see the blood bank rep tech walking by or something like that, having that knowledge to maybe request that in certain cases where you've had a trauma patient with undergoing prolonged resuscitation. You can most never go wrong with trying to advocate for a little bit more calcium and a little bit more clotting factors. Now, one place that you can certainly never go wrong is in the management of patient's core temperature. Hypothermia is severely detrimental to the trauma patient, severely detrimental to the bleeding patient. It severely, we're going to keep using that word severely impairs platelet function. At lower temperatures, the enzymes responsible for driving the coagulation cascade, of which there are many, there's many factors and there's many more enzymes, right? These enzymes that activate all of these factors and get the clotting cascade going, they require temperature to function. Even mild drops in temperature can limit the production of thrombin, delay fibrin formation, and ultimately just degrade clot stability. Additionally, platelets don't function properly in the cold either. their ability to adhere, activate, and aggregate at that site of injury drops off significantly with even, again, mild drops in body temperature. So without that primary mechanism of hemostasis, that secondary hemostasis cannot even be activated. And even if it is, it's going to be a much degraded process that is not going to adequately or sufficiently limit hemorrhage in the bleeding trauma patient, or at least in the cold bleeding trauma patient. So keep your patients warm. Use warm fluids, use warming blankets, use the warming cocoons called the Thermoflex that we have here at CareFlight. Hypothermia is not just uncomfortable for the patient. It's a coagulopathy waiting to happen that can very quickly kill your patient. So if you're dealing with a trauma patient who's bleeding and cold, TXA, rapid transport, and communication with the hospital about the need for FFP, cryo, and platelets, in addition to what we already carry, can save a life. And again, keep saying this, keep the patient, right? Pretty please keep the patient warm. It's one of the simplest and most effective interventions we can provide. As pre-hospital providers, you are the first line in recognizing and acting on these challenges. Recapping one more time, timely hemorrhage control, temperature management, and early communication can dramatically improve outcomes for these patients. And that's what it's all about, right? Thank you all for your attention. Thank you for joining me in this quick little rooftop session, and let's get back to it.
Hey guys. Hey, so this is Brian, one of our SWAT officers. We were doing a raid right up the street, kicking the door. He got shot for that right upper leg, so I put his tourniquet on, but I haven't had a chance to reassess it. He also got shot on the right upper chest. There's a chest seal on that right side. So it's all right, man. You're gonna be good.
You're still got bleeding. I'm gonna readjust the tourniquet.
Yeah, let me know if you guys need help with anything.
All right, man. Do you need anything? I'm gonna go put the cocoon on our stretcher.
Hurt. Oh my god, that hurts. Oh.
All right, bud. Relax. Give me a second tourniquet. No, we have no pulse. Hey, Blake, you ready to unload? Chest one's good.
Just the one, and nothing on the back.
Nothing on the back. Okay. How's his breath sounds now?
Good. It's good. Oh, issues. You guys want to carry him out or roll some more?
We're gonna roll him onto his left side and then slide her later.
Okay. On the left side to avoid the tourniquets. Chip.
You ready? Yep. 1, 2, 3. Sure. All right, ready. Hip. 1, 2, 3.
Ah!
All right, Brian, we got you, man. Are you ready, Butch? Ready? Just go all the way to the head and then I'll hop out. Okay. All right, stop there. Hey, we grab the sun? Yes. 1, 2, 3. Yep. We can drop them here and put it on monitor. Stop. Nice.
Hey, y'all. For this part of the monthly education, we're going to talk about the specific procedure of tourniquet conversion. We're going to talk about what it is exactly. We're going to talk about the indications, contraindications, the logic behind it, and then we'll go through the procedure itself. It is the downgrading of a tourniquet from being on and fully tightened to a wound packing material with a pressure dressing. So you might say that that sounds either one, like the kind of old adage of periodically releasing the tourniquet to reperfuse the limb. That's not what we're talking about. That is entirely separate. It's also an inappropriate modality, an inappropriate exercise to try to perform. You may say, oh, well, we could just remove a tourniquet if it's not appropriate, right? Or if it's not placed appropriately. How is that different? In the instance where you arrive on scene and you look and there's a very minor injury with no evidence of any profuse hemorrhage either before or after, and just take it off there. That is not tourniquet conversion. That's just the appropriate removal of a tourniquet that was unnecessary. Or what about if you show up and the patient has a tourniquet that's in place, but you can see that it's either not tight enough or it was just mechanically placed in some way where it's not effective, it's not even doing its job. The patient doesn't need one anyway, so you just remove it that way. That's also not tourniquet conversion. So specifically what we're talking about is you arrive to a patient where a tourniquet has been placed, it was placed effectively, and it was placed for an injury that was appropriate. But because of the time that it's been placed, and because of the effectiveness of the hemostasis that was involved in its application, you believe that you can convert this from being a tourniquet which is causing complete ischemia to the limb to wound packing material and a pressure dressing, therefore allowing for more perfusion to this limb in a time frame that is going to benefit the patient. So we've defined kind of what it is, what it's not. Let's talk about the indications for this. The indications for this would be a tourniquet that's placed on a patient where it was appropriate, and the expectation is that given your transport time and the time that the tourniquet has been in place, that you expect that this patient's tourniquet is going to be in place for greater than 2 hours. 2 hours is kind of that initial time frame where if you're expecting it to be in place for much less than that, the benefit is not outweighed significantly by the risk. we can just leave it on and allow the people who are going to be managing this patient definitively to make that decision on it. Now, let's talk about the contraindications. There are 4 main contraindications that we're going to cover. The first one is going to be if the patient is in shock. Not only does this procedure land very, very low on the list of priorities for us, is it something that is that much more beneficial than, say, giving blood, making sure that the patient is oxygenating and ventilating, making sure that we're managing other things that actually are associated with decreased mortality? No, definitely not. It's way, way down on the list. Not only that, it exposes the patient to a risk of further hemorrhage. Clearly, we don't want to even potentially risk more hemorrhage for this patient, so we're not even going to try and convert this tourniquet to a less extreme or less invasive. The second one would be any type of amputation, whether it be upper extremity or lower extremity. We wouldn't want to attempt this in a patient who has a complete amputation. The biggest reason why is, well, the benefit of tourniquet conversion is to allow reperfusion and while maintaining stasis on the actual injury site. If they have an amputation, we're not reperfusing it. So we lose all the benefit of it while increasing the risk itself. So at that point, no reason to try to attempt this. So if the patient's in shock, if they have an amputation, we're not doing this. The third would be if you cannot adequately monitor the site for continued bleeding after you convert the tourniquet, then this would not be indicated. So what does that mean exactly? If you have a lower extremity tourniquet placed and you're considering conversion, but you're in a 407, unless you're deciding that you're going to ride the patient back the entire way and that you're going to be watching that site the entire time to make sure that there is no continued bleeding, we're not going to try to do this on a patient who has a lower extremity tourniquet. The fourth one has more to do with time. So if a tourniquet has been in place for greater than 6 hours, it is a definitive no, you will not do this. The time frame in between the 2 hour and the 6 hour mark is kind of where there's a little bit more flexibility. Okay. Let's go ahead and run through the procedure. So equipment that you would need to perform this procedure. Obviously, a tourniquet would already be in place prior to you performing this procedure. In addition to the tourniquet that's already going to be in place, you'll need another tourniquet. You also need some type of pressure dressing or wrap and some wound packing material. So using this flag as our patient, we'll say that they have a lower extremity injury right where the sticker is. Again, we'll say that the injury was appropriately managed by the use of the tourniquet, and the tourniquet was effective in achieving hemostasis. Okay, so the tourniquet is in place. This patient is not in shock. They do not have a traumatic amputation. You're able to continuously monitor the site the entire time. So either this is in a 429, you're transporting them in an ambulance, or the patient is going to be ridden back the entire time and you can visualize it. And then lastly, it's been less than 6 hours. You feel as if you can manage this with a wrap and some wound packing material. So the procedure itself is going to look something like this. Extra tourniquet right here. First thing we're going to do is go ahead and apply the extra tourniquet. We're going to tighten the Velcro strap, but we're not going to tighten the windlass yet. So we're going to leave this loose. So if this was on just by itself, you'd still have perfusion, you'd still have a pulse to the side. We're just applying this right now. I'll explain why in a second. The next thing that we're going to do is take our wound packing material and we're going to pack this wound and make sure that we're following the procedure just like it's laid out in other portions of this monthly education. Then you're going to take your pressure dressing and we're just going to apply that. Again, we have this loose tourniquet applied, our brand new one. We have wound packing material and we have a pressure dressing. So now there's two schools of thought with this, either just all at once or over a period of time. So let's say we want to do it over a period of time. We're going to loosen this one turn, lock it back in place, make sure that the timestamp is back over, Probably about a minute or two later, we're going to do the exact same thing until this is completely loose. So now we have 2 loose tourniquets on, one that was previously used, one new and fresh one. Hemostasis is still achieved with this, and we've successfully converted the tourniquet. Again, we're going to continue to monitor this the entire time, make sure that we don't have any issues later on, but now this limb should be fully perfused. In this process, or later on during transport, if you do notice that there is continued hemorrhage, again, you would just reapply the old tourniquet. If for some reason this tourniquet is not effective anymore, say that the material itself has been stretched just through its application, that it's not achieving enough pressure to be able to cause hemostasis, or even the windlass is broken, some other reason why this tourniquet is no longer mechanically effective, that's why we have the backup tourniquet. Usually these devices are considered to be single use. They can handle a lot more than that. If you've ever had a training tourniquet placed on you, you know that this thing has gone through the ringer multiple times, and yet it's still able to do its job effectively. But especially in instances where things are being placed under stress, it certainly can result in mechanical failure. So that's why we have the second one in place. If this one fails to achieve hemostasis, then we can always just apply this second one, and making sure that when we're placing 2 tourniquets on, that there is not a huge gap in between, that they are close but not overlapping, to make sure that we're not creating space. So once that has been achieved, either the procedure itself was successful or it's not successful, either way we should have adequate hemostasis achieved at this point. And that is the end of the tourniquet conversion portion of this monthly education. Thanks.
We've been dispatched now to a drive-by shooting in Terrell, because where else would it be, with 2 patients. We believe one is a pediatric. We're going to be talking here about chest seals and junctional tourniquets, specifically improvised junctional tourniquets, since we don't currently have any commercial ones available to us at CareFlight.
Hey, bud,
Now what you got?
Oh, I've got a vein right here,
All right.
and right here.
I got junctional hemorrhage right here. I'm going to start holding
Okay.
pressure.
Shot up here.
Okay. Yeah, he's also got a chest wound.
We'll take a look, brother. Yep. Okay. Absolutely.
Chest seals right here. I'm going to keep holding pressure on this.
Yeah, this hemorrhage right here looks much more severe, so we're going to focus on that one first, okay? Before we put this on, I'm going to actually check that pelvis too, right here. All right, it does feel stable, so we just need to control that hemorrhage.
Cool. I got control of it right now.
We're going to use this T-pod right here. Roll it up under him while you're holding pressure, okay? All right, I'm going to raise your butt up right here. 1, 2, 3. There you go. You can come on down, brother. There you go. I'm going to reach up under here to grab it, okay? 1, 2, 3. All right, thank you, sir. All right, I'm going to take pressure. Will you pull some of this through for me? All right, I got it. All right, let's go ahead and place this right here. And you can just leave that right there. Now go ahead and grab that pressure bag and that bag of saline for me.
Okay.
You can go ahead and put that in the pressure bag. All right, and we're gonna run it under here, following that inguinal fold right there, okay? Wonderful. All right, you're gonna take over pressure.
Okay.
1, 2, 3, push. All right, we're gonna secure this, tighten this down. Coming across here. All right, keep holding pressure while I inflate this back, okay? How you feeling, buddy? You doing okay?
Yeah, I'm okay.
All right, man. Was there anybody else in the car with you?
Yeah, my kid was in the car too. I don't know what happened.
Okay, man.
This chest really hurts.
Hey, real fast, let's hemostat. These are hemostats right here. Can you access the top of that pressure bag? And and clamp it to the teapot, okay? So it doesn't slip down from underneath us?
Yep.
All right, we secure there? Mm-hmm. All right. I've got good pressure there.
Okay. All right, I'm gonna check his chest.
All right.
All right, yep. So I got a vented chest seal that I'm gonna place. Okay.
All right, beautiful.
When you're ready, we can roll them and check the other side.
Ready to go. All right, so we're gonna roll you this way towards me, okay?
Okay.
Can you reach across this way? And we're gonna go on 3. 1, 2, 3.
All right, I got an exit wound back here, but nothing else.
All right.
Can
Another
you
chest
hold
seal on
it
that
there
one?
for me?
Got it right there. Hey, bud, good news. Your Star of EMS tattoo wasn't hit, okay? You got a bullet wound back there, but that's safe.
Okay.
All right, 1, 2, 3, coming on back. All right, man, you said your kid was in the car with you also?
Yeah, I don't know what happened.
Okay, I see him over there. Aaron, you cool if I go get the kid?
Yep.
Awesome.
Just a baby.
He's a little hurt, but he's doing okay. I'm gonna bring him here next to you, all right, man? All right, brother, he's here crying next to you. We're gonna get him checked out. All right, Aaron, so we've got this wound right here on the leg. Which one of these do you want?
So for kids, instead of placing a tourniquet, you can just use a pressure dressing. We can go ahead and use this one.
Okay.
So go ahead and lift his leg up.
Okay.
And can you hold that?
I can, yes, sir.
Okay, I'll take over for you.
There you go.
All right, and that'll have a tourniquet-like effect.
Okay, got it. So what'd you say your name was, man?
Adam.
Adam. All right, Brian. So here, I'm gonna put your son on your chest real fast for a little bit of tummy time, okay? We're gonna wrap you guys up nice and warm. We're gonna throw you in the helicopter and get you out of here, okay? Boom. What do you want us to talk about with burping chest seals and stuff?
So I talked about it when I put it on. Because this is the one that's going to be facing up, it's ideal that it's the vented one, whereas the one on the back, because he's laying on his back, it does not need to be vented nearly as much. It's a really good idea and consideration. These valves can get clogged up pretty easy with blood. So in that case, it just acts as a seal. And if a tension pneumothorax starts to develop, you're going to need to peel this off and allow it to actually burp out. Probably the better consideration versus just immediately going to a dart.